Hello everyone, this is Dr. Meghna. You'll have my introduction video soon. But now let's get into the video. The anatomy of scalp. It's the first and foremost important topic you'll be learning in your first year. So try to pay maximum attention to every point. I have made this video in such a format that it can be directly taken into your notes. Or if you need this PowerPoint in the form of a PDF, please drop it in the comment section. I'll be happy to help. Scalp is the soft tissue covering of the cranial vault. Cranial vault is nothing but the top of your skull. Scalp extends anteriorly to supraorbital margins, posteriorly to superior nuchal lines, and laterally to superior temporal lines. I'll be demonstrating the landmarks in the next slide. This view of skull is called norma frontalis. It is the anterior or frontal view of the skull. And this is norma occipitalis. It is the back of your skull. Now, this is the supraorbital margin. Supraorbital margin is the upper margin of the bony orbit. It contains a foramina called supraorbital foramen. The supraorbital nerves and vessels pass through it. This is the external occipital protuberance. The superior nuchal lines extend laterally from the external occipital protuberance. These lines represent boundary between scalp and the neck. There are highest nuchal lines present above the superior nuchal lines, but this is not a constant finding. Layers of scalp. This is an important short answer question in your university exam. You can remember the 5 layers of scalp using the mnemonic scalp itself. S for skin, C for connective tissue, A for aponeurosis, L for loose connective tissue, and P for pericranium. I'll discuss about each layer of scalp in a different slide and also their clinical aspects clearly. The first layer is the skin. The second layer being the connective tissue, and the third layer is the aponeurosis. There are strong connective tissue bands that traverse the superficial fascia or the connective tissue or your second layer. They join the skin and the aponeurosis. So all these 3 layers move as a single unit. All these 3 layers are also present in your palm and soles. The next point is the skin of the scalp is thick and hairy. It also contains more number of sebaceous glands. You must have heard this. Your scalp is the most common site for sebaceous cysts. Fibers of many scalp muscles are inserted into it. The second layer of scalp is the subcutaneous connective tissue or superficial fascia. It has the richest cutaneous blood supply in the body. Vessels and nerves run in this layer. Going to the applied anatomical aspect, this is an important very short answer question. Why scalp wounds bleed profusely? You have to mention 2 points. 1. It has the richest blood supply, so even a small laceration can cause severe blood loss. 2. Normally, to stop bleeding, the vessels undergo vasoconstriction, but the arterial walls in this layer of scalp are attached to the fibrous connective tissue septa. So even in an attempt to contract, the septa pulls away the walls and are unable to retract to allow blood clotting to take place. The most effective method to stop this bleeding is application of local pressure. There's also another point. Why there is no necrosis in a large or avulsed flap of scalp with a narrow pedicle? The points are common. It has the richest blood supply, which is important for healing of scalp wounds. Healing in case of extensive scalp injuries can be expected if this pedicle or the source of blood supply is retained. So it should be sutured in place. The third layer of scalp is aponeurosis or Galea aponeurotica. It has the occipitofrontalis muscle. The occipitofrontalis muscle is made up of four muscular quadrilateral parts, two frontal bellies and two occipital bellies. Let's discuss about each attachment clearly. The occipital belly arises from the lateral two-thirds of highest nuchal line of occipital bone. Gap between the two occipital bellies is occupied by the epicranial aponeurosis or galea aponeurotica, which extends up to the external occipital protuberance and medial part of highest nuchal line. The frontal bellies attach to superficial fascia, particularly the eyebrows. It has no bony attachment. These muscles blend with the adjacent muscles like procerus, corrugator supercilii, and orbicularis oculi. The right and left frontalis muscles meet in midline, while the occipital bellies don't meet at all. Follow my pointer. This is the epicranial aponeurosis or galea aponeurotica. It blends anteriorly with the frontal belly of occipitofrontalis muscle. Posteriorly, it blends with the occipital belly. Posteromedially, it is attached to the external occipital protuberance. It blends laterally on either side with the temporal fascia and zygomatic arch. Temporal fascia is the fascia that covers the temporal bone. Let's see the nerve supply. The branches of facial nerve provide innervation to occipitofrontalis muscle. The temporal branch runs in front of the ear, ascends anteriorly to innervate the frontal belly on each side. The posterior auricular branch runs behind the ear and innervates the occipital bellies. Clinical anatomy of aponeurosis. Why deep scalp wound will gape open if aponeurosis is divided. If this aponeurosis is cut in deep transverse or coronal wounds of scalp, the edges of the wound will separate because of the pull of the occipitalis backward and frontalis forward. This is due to the tension of epineurosis produced by the tone of occipitofrontalis muscle. This can be prevented by suturing the aponeurosis properly. Fourth layer of scalp is the loose areolar connective tissue or subaponeurotic space, the space beneath the epicranial aponeurosis. Let's dig deep into the clinical anatomy. What is a black eye? The loose areolar connective tissue provides a plane above which the rest of the scalp moves. As you all know, the first three layers of scalp move as a single unit. The subaponeurotic space extends down beneath orbicularis oculi muscle into the eyelids. The frontal bellies have no bony attachment and they blend into the muscles of the eye. So bleeding anywhere beneath the aponeurosis appear as black eye due to blood tracking down from subaponeurotic space into the eyelids. The fourth layer of scalp is called the dangerous layer of scalp because the emissary veins pass here. These veins are devoid of valves, so they allow bidirectional blood flow and provide a pathway for spread of infection from scalp into the skull. They connect extracranial veins to intracranial venous sinuses. Infection in subaponeurotic space might lead to venous sinus thrombosis by means of these emissary veins. At vertex on either side of the sagittal suture, there are two foramina called parietal foramina through which parietal emissary veins connect scalp veins with superior sagittal sinus. This is your skin. This is a subcutaneous connective tissue. Epicranial aponeurosis. This is the subaponeurotic space between the aponeurosis and the pericranium. These are the emissary veins connecting the subaponeurotic space and the intracranial venous sinuses. The skull bones are joined by sutures. This is the diploe containing diploic vein. Fracture of cranial vault associated with tearing of dura mater and pericranium. The blood from the intracranial hemorrhage communicates with subeponeurotic space of scalp through this line of fracture. Signs of brain compression don't develop until the subeponeurotic space is full of blood. In this way, the fourth layer acts as a safety valve in this case. The last layer of your scalp is the periosteum or pericranium. The pericranium is the periosteum of your skull vault. It is loosely attached to the bone and is easily stripped off by subperiosteal hematoma. This periosteum is firmly attached to the bone at the sutures. So, in case of subperiosteal hematoma, the blood pools up between the sutures and the hematoma takes the shape of the bone concerned. This is due to tension between these sutures. Let's see the clinical anatomy. Subperiosteal bleeding is limited to one bone. I have already explained you this. Cephalohematoma. What is cephalohematoma? It is subperiosteal hematoma. It has risk of infant jaundice because RBCs are getting killed and bilirubin is getting increased. Let's see the next one. Corpus succedaneum. It is a harmless condition seen in newborn in long and difficult labor. It occurs due to excessive pressure on the skull during passage through the vaginal canal. It causes interference of venous return in the baby. It is temporary. It disappears after 24 to 48 hours of birth, and it is the edematous condition of scalp. It is often subcutaneous and extraperiosteal, unlike the cephalohematoma, which is subperiosteal. This corpus succedaneum can cross the midline, unlike the cephalohematoma, which is restricted to one bone between the sutures. It's better you make a table differentiating corpus succedaneum and cephalohematoma. This can usually come as a very short answer question in your university exam. It is very important. We are now done with the 5 layers of the scalp. Now let's get into the blood supply. There are two major arteries that supply the scalp. The first is the external carotid artery and the next is the internal carotid artery. The three branches of the external carotid artery ascend from the neck and supply the scalp. They are superficial temporal, posterior auricular, and occipital. There are two branches of internal carotid artery that reach face through foramina in the facial bones and supply the scalp. These are the supratrochlear and supraorbital. This is the medial one and this is the lateral one. You can see this clearly. You have to remember 5 arteries that supply your scalp. The first is frontal or supratrochlear, the supratrochlear artery. Next is the supraorbital. These both are branches of internal carotid artery. The next is the superficial temporal. It has two branches, the frontal and the parietal branch. The next is the posterior auricular behind the ear. The next is the occipital artery. These three are branches of external carotid artery. So you have to remember just 5 arteries: the supratrochlear, supraorbital, the superficial temporal, posterior auricular, and occipital. The supratrochlear and the supraorbital are the branches of ophthalmic artery. Let's see another clinical anatomical aspect of scalp. Why is it an emergency when a tourniquet or string is tied tightly around your head just above the ears and eyebrows? As all the superficial arteries supplying the scalp ascend from the face and neck, a tight tourniquet causes excessive pressure on these arteries. So circulation to the scalp is affected. What you have to do? Insert a pen or a pencil into this loop and rotate. This relieves pressure on the arteries and the circulation is re-established. Let's see the venous drainage of scalp. The veins accompanying the arteries not only drain the scalp but also the cancellous bone of calvaria by way of diploic veins. What are diploic veins? What is a diplo? Let's see. This is the outer table of the skull. This is the inner table of the skull. Both are made of cortical bone. The space in between the cortical bones is the cancellous bone. This is called the diplo. It has diploic veins. Let's see the actual venous drainage of entire scalp. This flowchart is extremely important, so note it down. The supratrochlear vein combines with supraorbital vein to form angular vein at the angle of the eye. The angular vein drains into facial vein. The superficial temporal vein travels near the parotid gland. It joins with maxillary vein and forms retromandibular vein. The retromandibular vein has two divisions, the anterior division and the posterior division. The anterior division of retromandibular vein joins the facial vein to form common facial vein. The common facial vein ultimately drains into internal jugular vein. The posterior division of retromandibular vein joins with posterior auricular vein and drains into external jugular vein. The external jugular vein finally drains into subclavian vein. Hope this is clear. I'll show you the picture of it. This picture, you have to draw it in your exam. It is extremely important. Here is the supratrochlear vein. Here is the supraorbital vein. They both join to form angular vein at the angle of the eye. The angular vein joins the facial vein. The facial vein joins the anterior division of retromandibular vein. This is your retromandibular vein formed by the fusion of superficial temporal and maxillary veins. This is the posterior division of retromandibular vein. It joins with the posterior auricular vein and drains into external jugular vein, which ultimately drains into subclavian vein. The anterior division of retromandibular vein joins with facial vein to form common facial vein, which drains into internal jugular vein. You have to remember this W so you can easily get through it. What are emissary veins? I have told this before. They connect the intracranial venous sinuses to extracranial veins. What is their clinical significance? They determine the spread of infection from extracranial foci to venous sinuses. We have already seen this. They are valveless and connect extracranial to intracranial. They also provide alternative drainage pathways in venous sinus thrombosis. Let's get into the lymphatic drainage of scalp. The anterior half of the scalp is drained by preauricular or parotid nodes. The posterior half of the scalp drains into occipital and mastoid nodes. All these lymph nodes finally drain into deep cervical lymph nodes. There are no lymph nodes within the scalp. These are the preauricular lymph nodes. You can follow my cursor. Scalp on the anterior half drains into these nodes. The scalp on the posterior half drains into occipital nodes, mastoid, and posterior auricular lymph nodes. All these lymph nodes drain into deep cervical lymph nodes. Let's get into the nerve supply of scalp. Have to remember 5 nerves in front of the ear and 5 nerves behind the ear, out of which 4 nerves are sensory and 1 is motor. Let's see the nerve supply in front of the ear. 4 sensory nerves: supraorbital, supratrochlear, zygomaticotemporal, and auriculotemporal. The sensory nerves of scalp in front of the ear reach through foramina in bones except auriculotemporal nerve. Auriculotemporal nerve doesn't come through any foramina to supply the scalp. This is the auriculotemporal nerve in front of the ear. These are the zygomaticotemporal nerves. This is the supratrochlear and this is the supraorbital. Let's see nerve supply of scalp behind the ear. 4 nerves as usual. This is the greater auricular nerve. This is the lesser occipital nerve. This is the third occipital nerve and this is the greater occipital nerve. This diagram is very important. You have to draw it in your exam. Follow my cursor. This is the supratrochlear nerve. This is the supraorbital nerve. Both are branches of ophthalmic division of trigeminal nerve. This is the zygomaticotemporal nerve. It is a branch of maxillary division of trigeminal nerve. This is the auriculotemporal nerve, which is a branch of mandibular division of trigeminal nerve. These four nerves supply the scalp in front of the ear. And this is the temporal branch of facial nerve. It supplies the muscles. Motor supply to the scalp. Let's see the nerve supplying scalp behind the ear. The greater auricular nerve, lesser occipital nerve, greater occipital nerve, third occipital nerve. All these four nerves are branches of cervical plexus C2, C3 cervical nerves. The posterior auricular branch of facial nerve supplies muscles behind the ear. Hope this is clear. Behind the ear. Hope this is clear. Look into this flowchart. You can just mention this flowchart in your exam, draw the previous diagram. That would be enough for a 4 marks question. The nerve supply in front of the ear. Sensory nerve supply, motor nerve supply. What are the sensory nerves? Supraorbital, supratrochlear, both of which supply the temple. The auriculotemporal and zygomaticotemporal both supply the forehead and front of the scalp. What is the motor supply of scalp in front of the ear? The temporal branch of facial nerve. Let's see nerve supplying the scalp behind the ear. Sensory and motor. Similar. Sensory involves cervical nerves C2 and C3 plexus. Greater auricular, lesser occipital. Both supply the skin behind the ear. The greater occipital and third occipital. They extend to vertex and posterior scalp. The motor supply behind the ear is posterior auricular branch of facial nerve. That's all for today. The scalp topic itself is extremely important. It can alone come as a long answer question in your exam. Or they can ask you some clinical aspects like what are emissary veins, why is it called the dangerous area of the scalp, and you can get short answer questions like the venous drainage, nerve supply, the arterial supply, all 5 layers of scalp. So pay attention, jot it down, write your notes, revise. That's the key. Thank you.